anything like this beginning 5. This is your mnemonic. I don't know what you're going to do after, but to start. Okay, so living in Oklahoma, most of us kind of already had a little bit of previous exposure to diabetes. What is one of the reasons we tend to know a lot about it in Oklahoma?
We have a lot of it.
Because we're unhealthy. That's one of the reasons we tend to have a higher weight in this area, which contributes to that. What else about Oklahoma might give us a higher rate of diabetes? Does anybody know?
Fried chicken?
Fried chicken sounds yummy, yes. That would be, yeah, fried foods are not our friend necessarily. Does anybody have another one?
Indians.
Yeah, and I've got that answer in Tonkawa too. Yes, Native Americans especially can be predispositioned to have this disorder, in addition to some other ethnic groups that we'll talk about, but that is one of the reasons too that we have a high rate of diabetes in Oklahoma, because we have a higher rate of Native American population than some other states. So if you haven't already encountered this in clinicals, I know where we are in Ponca, we're on an orthopedic floor and we see lots and lots of amputations. So it's a lot, we deal with a lot of that. That may be true on the units you guys are on in other communities too, but it's definitely something you will deal with literally every single day in your nursing career. It's rare when all my students don't have finger sticks when we're up on the floor. So, obviously significant health issue, causes significant disability and expense nationwide. Consistent daily management of the disorder is the key to preventing those long-term debilitating effects. So that's our highest priority with our clients. We want to prevent those acute complications, but the most important thing for their long-term health and wellness is that we get good glucose management going on, in addition to managing blood pressure and lipids. But that's our major goal, is to prevent them from having those long-term complications, which we'll talk about, but you guys kind of already started touching on kidney issues, issues with vision, circulatory issues that we'll talk about more as we go on. So diabetes is all about the pancreas to some extent. Pancreas has two parts of its function, has exocrine functions that relate to digestion, but typically we talk about it more because of its endocrine functions regarding blood glucose control. Now we know a little bit about the islets of Langerhans because a lot of us have heard about beta cells before that produce insulin. But that's not the only way that the pancreas influences glucose control. It also has alpha cells that secrete glucagon, and this prevents hypoglycemia by triggering the release of glucose from cell storage. So it's kind of a balancing act, basically, that the pancreas does. Beta cells produce insulin. That obviously prevents hyperglycemia. And what insulin actually does for us is it allows the cells to take it, use, and store the glucose that we get from carbohydrates, fat, and proteins. So that's why we end up with a high glucose level in the blood, is basically that the cells can't take it in without insulin. It has to have insulin, and I think that next slide actually says that. Insulin is the key that opens up the cell to glucose. So that's the real problem there, is that it doesn't matter how much glucose they have, and it's not even necessarily that they're taking in too much glucose, it just can't get into the cells to use this energy unless we have some insulin on board to work with. Additionally, it stimulates glucose uptake in the muscle, which we talked about, but insulin does some other things that cause some of our complications from diabetes. Suppresses liver production of glucose and VLDL. So what is VLDL? Still water. Do you know what that is? If HDL is a high density lipoprotein, does that give you any hint?
Very low density lipid protein.
Right, and so is that a good thing or a bad thing, do you think, the VL kind? If HDL is good, then
VLD is very bad.
Yeah, VLDL is very bad. And so when we lose insulin, that's going to be produced more because we no longer have that suppressing factor in there. Insulin also promotes glycogen production and storage. So glycogen is kind of how we store glucose in our body for later use if we need it. So when we don't have insulin, we can't store it basically, so it has to stay in the bloodstream. That's another reason that it stays in there longer, is of course we're not able to change it into glycogen so that we can store it. So overall, insulin prevents hyperglycemia and helps us maintain normal lipid levels. And as you see when you look at that slide, then that kind of makes sense with the complications that we start to see over time with diabetics who don't have insulin in their system to use in those ways. Hallmark symptoms, we've kind of covered these. Polyuria is excessive and frequent urination. This is an osmotic effect that results from the high glucose levels in the urine. So they've got a lot, so if you think back to fluid and electrolytes, they've got a lot of glucose in the urine, it's gonna pull extra fluid into the urine, and that's why we see that effective dehydration with hyperglycemia, because the glucose levels get even higher in the urine, pulls more and more fluid until they become dehydrated. Polydipsia is gonna follow that because their body's thirsty, because they're losing liquid too quickly, and so they're gonna wanna drink more too. Polyphagia results from kind of a different mechanism. It's actually a result of cell starvation. So they have all this fuel right there in the serum, but it can't get into the cells. So their cells are still starving. So their cells still want nutrition because they're not getting it even though it's there without insulin. The acute complications that we look at. So we're going to talk a lot more about chronic, but there are some acute ones too that you'll cover more next year. These are glucose related, all of them, and they're all emergent. And you kind of just for reference, so you know what they are. We will talk a lot more today about hypoglycemia. The other two we're not really going to talk about today. Chronic complications. So these are related to long-term vascular changes that occur with poor glucose regulation. They cause early morbidity and mortality for these clients. There are two types, macrovascular complications and microvascular complications. So macrovascular are the ones that are going to occur in large vessels. Microvascular ones are the ones that occur in small vessels. Eventually, all the vascular changes lead to impaired perfusion and cellular ischemia. What's ischemia? Tom, go on. You're up next anyway. What? Okay, yeah, ischemia is kind of, a term for poor tissue perfusion. It's basically telling us that it's not getting enough nutrition that it needs. What follows ischemia if it's not fixed? Infarction, which is what? Cell death, right. So eventually, if these tissues don't get enough nourishment, they're going to die.
Good day.
Yes.
Can you repeat that last statement about ischemia?
Yes. So ischemia has to do with poor tissue perfusion, like they're not getting enough nutrients, basically. So when you talk about cardiac ischemia, that's kind of when we get that pain going on. And then it's followed by infarction if the cells continue to be in that situation. So eventually you can get tissue death. And that's what leads us to those amputations, basically, is that, sometimes it's a combination of wounds and infections as well, but it also has to do with the fact that the tissues don't get enough to, feed and regrow and fight infection, basically, because the circulation is cut back. A lot of different reasons, but the vascular changes that go along with having high blood pressure. The question was, why is the circulation cut back? The vascular changes that go along with having high blood sugar, high blood pressure, and the high lipids that go along with diabetes eventually lead to severe atherosclerosis effects in both large and small vessels. Long-term complications are directly related to chronic hyperglycemia that occurs with poor glucose regulation. Improving glucose control is the only way to prevent the onset and progression of those long-term complications. There's an interesting, you don't have to memorize this, but for every 1.1% drop in hemoglobin A1C, there's a 35% reduction in microvascular complications of the eyes and kidneys. So for every one spot we can take them down, they reduce the risk by a third of kidney and vision complications. So it's helpful, and I think I say this later in a slide, but sometimes a lot of these clients are so used to running with high blood sugars that they actually will feel better, kind of up in the upper hundreds, 200s, like to them in the short term that feels better. So it's really important to teach them about the long-term complications and what can happen if they don't control, because sometimes controlling at the time doesn't feel worthwhile. It's hard. It's just like us with anything else, like I said, when we live in Oklahoma, a lot of us, me especially, are overweight, and it's hard to think about the long-term complications of that on a daily basis when I really just want to eat a cheeseburger and a hiccup. So similar things, I always think that it's important that we sympathize with our patients because we know all of these things, but it's still hard to manage these kind of disorders day in and day out, even when you know what the consequences are of not managing them. And I am kind of starting things. We've got like 2 minutes left and go any further. So we will probably just start with the macrovascular stuff on Thursday. Does anybody have any questions about anything today?
Are we trying again?
Okay.
How
No,